Hello and welcome back. So, continuing our discussion about the airway management, in this video we will talk about the extraglottic airway. So, the extraglottic airway refers to a diverse collection of devices that are blindly inserted into the pharynx to provide an airway for ventilation and delivery of anesthetic gases without the need for tracheal intubation. So the extraglottic devices create a patent airway without entering the trachea. And example for an EGD is the laryngeal mask airway you can see in this picture here. Now an EGD is less invasive than tracheal intubation because it doesn't enter the trachea, and it also provides a more reliable airway than a face mask for spontaneous ventilation and for positive pressure ventilation. Now, extraglottic devices are most commonly used in the emergency department after a failed endotracheal intubation, but may also be used primarily during cardiac arrest, and they are also used for difficult mask ventilation or as part of the rapid sequence airway procedures. Also, it is critical to always have an appropriately sized extraglottic device available during airway management to place the device in case difficulties encountered, but don't rely on the extraglottic device to the exclusion of a surgical airway when critical hypoxemia is encountered. And the EGDs don't protect the trachea from obstruction or aspiration, so they are less definitive of an airway than tracheal intubation. And that is why they are used for several hours until a definitive airway using an endotracheal tube can be secured. Now let's talk about the advantages. So those include faster and easier to apply than an endotracheal tube because they can't be applied blindly, and there is reduced anesthetic requirement compared to endotracheal tube, and that does not mean that extraglottic devices can be applied on an awake patient, so they definitely require a level of anesthesia where the airway reflexes are gone and the patient is unconscious. And there is reduced need for muscle relaxation with the EGDs, and that also doesn't mean that muscle relaxation is not required. There is definitely a level of muscle relaxation required for the extraglottic device to work well. Advantages also include avoidance to other risks that comes with tracheal intubation, such as trauma to teeth with the laryngoscope, and sore throat and bronchospasm. Disadvantages include smaller seal pressures than endotracheal tubes, and this means ineffective ventilation when higher airway pressures are required, and also EGDs provide no protection from laryngospasm, and older EGDs models provide less protection from gastric regurgitation and aspiration than newer models. Now let's talk about the classification. So EGDs are classified into supraglottic airways and retroglottic airways. So supraglottic airways include a mask that sits internally over the glottic opening. Example for a supraglottic airway is the laryngeal mask airway you can see here. So it includes this mask here that sits over the glottic opening and provide an airway for ventilation. On the other hand, retroglottic airways include a dual balloon device that sits within the proximal esophagus and include the distal and proximal balloons to direct the ventilation that occurs through the holes between the two balloons into the airway. Now, many of these devices include a channel for gastric decompression, and this theoretically lessens the risk for aspiration, and some EGDs facilitate blind, or endoscopic intubation. Now, all EGDs can be placed without directly seeing the glottis, which is called blind placement. Now let's talk a little more about each type of the EGDs. So starting with the supraglottic airways, the SGAs, they create a seal over the glottic opening to create an airway for ventilation. There is many examples for these devices, such as the Ambu Orgain, the laryngeal mask airway Supreme, Protector, and Fast Track, and then the Entel surgical iGel, and the Gas AirQ. And the most commonly used SGA and extraglottic device in general is the laryngeal mask airway. Now the SGAs can be placed in under 30 seconds, making them advantageous for emergency use and has a success rate of 98%. Serious complications are rare with the SGAs and usually result from nerve and soft tissue trauma in the pharynx during placement. The retroglottic airways, on the other hand, the RGAs, include a dual balloon device that pass behind the glottis and into the esophagus to create a seal, allowing oxygen to be delivered directly to the trachea. Examples for those include the King laryngeal tube, the esophageal trachea combi tube, and the Rush easy tube. So the idea of the retroglottic devices is that you have two balloons, like you can see in the King laryngeal tube here. So two balloons, and when inserting the King laryngeal tube into the patient airway, the first balloon would go into the esophagus, like you can see here, and it would inflate to prevent the air from going to the esophagus, and the other balloon inflate just above the glottis here, so it inflates here, preventing the air from going up. So when you give the air through the King laryngeal tube here, it would pass directly into the trachea. And like the SGAs, most complications of the RGAs result from trauma to the pharynx during placement. And with that, we reach the end of this video. Thank you guys for watching. Please give us a like, comment your ideas and questions, and subscribe. And please consider joining the channel by hitting the join button near the subscribe button down or through the link in the description of this video.